Boom. Okay, so welcome everyone. Thank you for coming. My name is Selena Robinson and I run Neck Cancer Foundation with the help of my lovely ambassadors, of which there are 3 of them here today. And I'm really looking forward to hearing your talk, Dr. Sunita Agarwal. And Kate, I'll pass over to you for your intro.
Okay, so yeah, it's my pleasure to introduce Dr. Sunita Agarwal today. So she is going to talk about her work on genetics and pathophysiology of MEN1 and related MEN1-like disorders. And she's based over at the NIH, or NIDDK at the NIH, should say, over in the US, where she's been studying MEN1 for a long time. And I've been hearing about her research for a long time as well, because we seem to keep cropping up at the same places. So I'm sure this will be a very, very interesting talk. So please take it away.
Okay, let me share my slides. Okay, so give me a moment, please. Sometimes these things take time, but there we go. It's got some privacy things on, and now I will have to see what is going on here.
The age-old challenge.
Going to quit and open again, so let's see.
You should hopefully have permission to share them. If not, we can. Yeah.
No, it should have, because I'm sure we've got it. We have got it all set up.
Okay, let's see. Share screen.
If I also make you a co-host, then
yeah, that should do it.
No, it won't do it. Okay, let me try it one more time in a different way, and if it works, I'm good. Oh, now it wants my password, and I hope this one is going to work.
That's the second biggest challenge.
You know, if I need admin, then nope.
Well, the other alternative, if you want to email me your slides, if you can, I can show them instead, if that would help.
Okay, let me try this one more time. Yeah, I will do that immediately. Yes, yes, that's a great idea. I'm going to leave the meeting and come back.
Okay. Failing that, one of us will have to talk for. I'll talk about MEN1 research for half an hour instead. No, you've heard me before. You don't need to hear me again. Hopefully she comes back and she hasn't run away.
I don't know where she's gone.
Maybe she's just bailed. That's it.
Oh, what? Yeah.
Yeah, some institutes are a bit funny on passwords and permissions for external meetings. So you can have some fun games with, oh, okay, she's come back. This is a good sign.
Yes.
Good sign, but am I going to be allowed to share the screen is the question. Okay. Yes. Perfect. And everybody can see my screen, right?
Yeah.
And hear my voice. Yeah. Okay. Thank you, Kate, and hello, everyone. Before launching into the presentation, I would like to thank Dr. Haidira Rivero of NCI for her outstanding collaboration and for inviting me to present this lecture on the Netchatter platform. And as you know from the nice introduction that Kate has done at the NIH, we have a long-standing interest in familial and sporadic endocrine tumors, We mainly study endocrine tumors associated with the MEN1 and related disorders. The theme of today's presentation follows the rationale of our work, which is to identify genes that from activation or inactivation predispose to endocrine tumor development and to perform functional analyses of the proteins that they encode. And we hope that our studies will help to facilitate clinical diagnosis, understand disease mechanisms, find potential druggable targets for therapy, such as an acquired protein-protein interaction that can be disrupted, or an overactive protein in a pathway that can be inhibited. And this has always been my first and my favorite slide to explain, and it takes a while, so please bear with me. MEN1 is an autosomal dominantly inherited tumor syndrome. MEN1 has the largest variety of tumor types and the broadest tumor spectrum associated with any tumor syndrome. Most tumors are benign. These asterisks indicate the location of tumor types with significant malignant potential. The three main endocrine organs affected are the pituitary, the parathyroids, and the endocrine pancreas. Shown in this picture is tumor penetrance at age 50. Patients develop tumors that appear in no specific order. Primary hyperparathyroidism due to parathyroid tumors is the most common and usually the earliest endocrine expression of MEN1, which is seen in 80 to 100% of MEN1 patients by age 50. Pituitary tumors are most commonly prolactinomas, and among the gastrin-secreting tumors, 15% can progress to an aggressive malignancy. Other tumors associated with this syndrome are the skin lesions and the carcinoids. Foregut carcinoid tumors can be located in the bronchus, thymus, or stomach. There are other tumors, the smooth muscle tumors, leiomyomas of the uterus or esophagus, central nervous system tumors, meningioma and ependymoma. And we have the non-functioning tumors of the adrenal cortex and tumors of the adrenal medulla. And recent descriptions of twofold excess of breast cancer in MEN1 patients. Although there is no gender bias in MEN1, a few tumors tend to be high in males or females, such as prolactinoma in females. And from Dr. Adele Mandel's work in our branch, we know that thymic carcinoids are predominantly seen in males, and this is also seen in our cohort of MEN1 patients. Patients are predisposed to all these tumors due to a germline heterozygous mutation in the MEN1 gene with near 100% penetrance by age 50. The MEN1 gene was cloned in 1997 by a great collaborative team at NIH with the help of a few extramural labs. This is me in the bottom left in the white sweater, and you can also recognize Francis Collins over here, top right, and some of you may recognize some other people in the photo. It was a great team. And among all of them, I have continued to work in the lab on MEN1. The MEN1 gene was cloned in the pre-genome sequence era by positional cloning, not only at the NIH, but also by a large collaborative group in Europe. The MEN1 gene is located on chromosome 11q13, spans about 9 kb with 10 exons. Exon 1 is non-coding. We named the protein product of MEN1 as Menin. It has 610 amino acids in its coding region. The gene is conserved in vertebrate species, and there is a fly ortholog, but this gene is not found in the worm or yeast. 70 to 90% of familial MEN1 index cases show germline mutation in the MEN1 gene, which is the first hit. Tissue-specific somatic loss of heterozygosity from loss of the normal allele is seen in the tumor DNA, which is responsible for subsequent tumor formation, which is a classic tumor suppressor effect. In sporadic tumors, the two hits to the MEN1 gene are both somatic. There is tumor heterogeneity among family members carrying the same germline mutation, so there is no obvious genotype-phenotype correlation. A significant fraction of sporadic parathyroid tumors, lung neuroendocrine tumors, gastrinoma, and non-functioning pancreatic neuroendocrine tumors show somatic MEN1 mutations. And surprisingly, MEN1 mutations are rarely found in sporadic pituitary tumors. Not all tumors have loss of heterozygosity at 11q13 for the biallelic loss. And there are also few sporadic tumors that show single copy 11q13 deletion, but without an MEN1 gene mutation. When one looks at the germline and somatic mutations in the MEN1 gene, it is quite obvious on the slide that they are spread over the entire coding region from exon 2 through exon 10. We have not updated this slide in many years because we ran out of space. On top of the gene diagram are drawn the protein truncating mutations, nonsense and frame shift. On the bottom are the missense and in-frame codon changes. Not shown are the few large deletions that are seen in about 2% of MEN1 cases. The germline mutations are drawn close to the gene diagram, and the somatic are represented by different colored shapes. There is no clustering of the germline or somatic mutations. No particular color is clustered at any spot, so no genotype-phenotype correlation and no hotspots. Majority of the protein truncating mutations would disrupt the nuclear localization signals located here in exon 10, predicting functional consequences due to defective localization of menin. Shown in this pie chart is the distribution of germline MEN1 mutations. And the distribution is similar for somatic mutations. I've pulled out of the pie the missense and the in-frame insertions and deletions because some of them may be variants of uncertain significance. And ACMG classification based on the guidelines that are suggested by this American College of Geneticists can be used to classify such variants into benign or pathogenic. Also, the structure of menin may be useful to predict functional consequence, although it is kind of hidden by this right column where all of us are shown in the camera, but that's okay. What I'm trying to point out over here is this amino acid shown in yellow, which resides in this protein-protein interaction pocket of menin. Now, this could predict loss of interaction with important protein partners and functional inactivation. So the structure of menin could be very useful to determine whether the variants that we are looking at in this missense and in-frame insertion deletion categories could be pathogenic or not. So 70 to 90% of familial MEN1 cases presenting with the three main endocrine tumors show germline mutations in the MEN1 gene. However, in cases with MEN1-like disease, the chance of finding an MEN1 mutation is very low. These are index cases with as few as one of the three main tumors. One could consider at least two reasons for this low mutation frequency. Mutations could occur in regions of the MEN1 gene that are not analyzed by the mutation detection, such as non-coding regions and regulatory regions. Or mutations could occur in genes which other genes which could explain the clinical phenotype. Now, here are the main genes associated with MEN1-like disorders, with at least one characteristic tumor that overlaps with MEN1. In syndromes with pituitary tumors only, such as FIPA, familial isolated pituitary adenoma syndrome, mutations are seen in the AIP gene in 50 to 50% of cases. Patients with XLAG, X-linked acrogigantism, show GPR101 mutation or duplication. In syndromes with parathyroid tumors, the hyperparathyroidism jaw tumor syndrome patients and parathyroid cancer patients show germline mutations in the CDC73 gene. Familial isolated hyperparathyroidism patients show activating mutations in the GCM2 gene, which is a master regulator of parathyroid gland development. In an MEN1-like disorder, MEN4, which has features similar to MEN1, germline heterozygous mutation is seen in less than 4% families in the cell cycle inhibitor gene CDKN1B. And recently, a possible MEN5 with, again, features similar to MEN1, parathyroid adenoma, pituitary adenoma, pheochromocytoma, paraganglioma. And these patients are showing germline mutation in this gene called MAX, which is part of the MIC-MAX-MAD transcription factor complex. And MAX mutations were seen in 2 families with MEN1-like features. So there are still many cases in each syndrome without a known germline mutation in the main genes. So these are up to 30% of MEN1 cases, mainly with the pituitary and parathyroid tumor combination, 50 to 85% of cases with FIPA, 40% of hyperparathyroidism jaw tumor patients, and 82% of the FIHP patients. So how can we find these missing genes? There's been a lot of interest in identifying the genetic cause of multiple tumors in patients with MEN1 and MEN1-like disease. And these are efforts mainly for looking at germline and somatic mutations by exome genome sequencing or gene panel sequencing. So let's look at 3 recent studies. This first study is from Brazil by Carvalho et al. In 2018. They looked at 96 MEN1 index cases, and they analyzed the mutations in this multi-gene panel, which included MEN1, AIP, and 4 different CDK inhibitor genes, P15, P18, P21, and P27. And they also analyzed gene deletions in some of these genes by this technique called MLPA. They found 60 cases with MEN1 mutations, which means 16 were mutation negative. And what was very good about this study is that they also interrogated the non-coding regions of the MEN1 gene, the introns, the UTRs, untranslated regions, or the regulatory regions, and no mutations were detected in these non-coding regions of MEN1. So one of the scenarios that I posed about not finding mutations in MEN1-like cases and those mutations residing in regions that are not routinely tested in mutation analysis, now we can throw that one a little bit out the window now. The second study is from Sweden by Backman et al. In 2019. They had already performed MEN1 mutation analysis of 128 index cases, of which 33 were negative. Then they performed whole genome sequencing of 14 MEN1 mutation negative cases. What did they find? Surprisingly, they found 3 cases with an MEN1 mutation. And these are with classic MEN1 features: parathyroid tumors, PNET, adrenal tumor, parathyroid tumor, PNET, or pituitary tumor. So they missed these mutations in the initial analysis. They found 1 patient with the mutation in the calcium sensing receptor gene. And this patient had a feature of parathyroid tumors and a liver met of unknown primary, perhaps a neuroendocrine tumor. And the third case that Kate Lines has published is from a CDC73 deletion, although not in this paper, but from the next paper that I'm going to describe. And this patient's brother had parathyroid cancer. So at the end, they were left with 9 mutation negative cases. Now, this is the paper where I think Kate has published that last mutation, the CDC73 missense. Now, this study is from a group in the USA and UK. This was a very interesting study. What they were trying to do here is to look at 362 acromegaly patients with pituitary tumors and trying to identify whether any of those patients had a MEN1 associated tumor. So what they found were 24 index cases with at least 1 other MEN1 associated tumor. 22 had acromegaly and a parathyroid tumor, which they classified as acropara. 2 had acromegaly and a neuroendocrine tumor that they described as acronet. They screened the coding regions and intron-exon junctions of all these genes and also performed deletion analysis in a subset of these genes. All they could find was 1 missense mutation in the CDC73 gene in this acropara category. So 23 were mutation negative. So summarizing the main findings of these 3 studies, let's see what those main findings were. They found germline MEN1 mutations that were missed in prior sequencing. So perhaps these are due to improvements in sequencing and analysis techniques. So it may be worthwhile to revisit the mutation analysis of at least those familial cases with 2 or more MEN1 associated tumors. And we have done that in our MEN1 cohort here at NIH. And we did find a few cases of MEN1 mutations among them. The second main finding is that they found rare germline mutations in other genes, such as the calcium sensing receptor or the CDC73 gene. And non-coding region mutations were not found in the MEN1 gene. So the conclusions about germline mutation negative MEN1 cases is as follows. These patients are showing random occurrence of 2 sporadic MEN1 related tumors, or a rare occurrence of an MEN1 related tumor in another syndrome. The multiple tumors could arise from mosaicism, from de novo post-zygotic mutations in the MEN1 gene or in some other genes, or these patients are presenting with a distinct clinical entity with an as yet unknown germline genetic cause. Next, let's look at the features of these MEN1 mutation positive and mutation negative cases. Germline MEN1 mutation positive cases clinically show 2 or more MEN1 associated tumors. These are familial cases with 1 MEN1 associated tumor and a first degree relative with MEN1, or they are sporadic cases with no family history of MEN1 associated tumors. And genetically, there could be MEN1 mutation positive cases who are asymptomatic, and these are usually young individuals. And here we know that there is near 100% penetrance for MEN1. Germline MEN1 mutation negative cases clinically show 1 or more MEN1 associated tumors. They are older at the time of diagnosis, and they do not exhibit a third MEN1 associated tumor. So what are the characteristics of germline MEN1 mutation negative cases? These are data from a recent analysis published by the MD Anderson group. The brown line is for mutation positive cases and the blue line is for mutation negative cases. Both the first and the second primary tumor are observed at a later age in the mutation negative cases, this blue line on the right. And the third tumor is almost never seen in the mutation negative cases. And the overall survival is better in the mutation negative cases. I also want to show you this another study. This is from the Netherlands in 2016. In the last column, we are looking at the mutation negative cases, and highlighted in this red box, we see that they are mainly showing parathyroid and pituitary tumors. The other tumors are rarely seen. Now, this still follows the definition of clinical MEN1, a case with at least 2 tumors of MEN1. And again, we have similar data in our MEN1 cohort at NIH who are positive or negative for the MEN1 mutation. Here we can consider 3 scenarios for these 3 MEN1 gene mutation cases, just like I had alluded to before. Is it a distinct syndrome? Is there mosaicism? Or is it a random occurrence of 2 tumors in an individual? So many groups are searching for the genetic cause in these patients, and I think such studies may benefit from a collaborative effort. So to summarize this part about mutation analysis, this slide shows the significance of finding genes for these familial MEN1 and related states. MEN1 is also mutated in up to 35 to 40% of common endocrine tumors, sporadic parathyroid, non-functioning PNETs, and lung nets. CDC73 is also mutated in 70 to 100% of parathyroid cancers. And the first FIHP gene GCM2 is fairly new, so its role in clinical management is not yet established. Overall, finding these genes is significant because genetic testing can help to confirm the clinical diagnosis. Genetic testing and families can help to identify mutation carriers for early clinical monitoring. and screening for syndrome-specific tumors. And most importantly, it can also help to exclude non-carriers and exclude them from such lifelong clinical screening. Genetic testing in young patients with parathyroid cancer who present with multi-gland atypical or cancer. Genetic testing in those cases can help to identify the respective syndrome, and it has implications for family members to assess first-degree relatives. So clearly, mutations in the MEN1 gene are important drivers of both familial MEN1 and in some sporadic NETs. So studying its encoded protein menin may help to identify disease-associated pathways. Menin is a protein with 610 amino acids. Its molecular weight is 67 kilodaltons. Menin is ubiquitously expressed, and it resides predominantly in the nucleus because of its multiple nuclear localization signals. Menin does not interact with itself, has no dimerization domain, has no DNA binding domain, and there is no predicted enzymatic activity. In 2011, Matthew Meison's group showed that menin can undergo phosphorylation at some serine and threonine residues. And these residues are located in this light blue domain, which is hidden on the right side, and which are really not hit by missense mutations. And this 3D crystal structure of menin was published in 2012. Many groups have shown that in cell culture models, menin overexpression affects cell proliferation and causes apoptosis. There are many interacting partners of menin, which were identified by work from different groups. There are about 40 different protein partners, and with the potential to affect a large number of different pathways and signaling cascades. So what we know about menin and its targets in general is shown on this slide. Because menin does not show homology to any known genes or proteins, most of the insight about menin's actions have come from its association with various proteins. And in this diagram, on the arrows are names of the menin interacting proteins, and the arrows are pointing to the functions of these proteins. I really don't want you to look at every gene and every function. This image is color-coded. Shown in green are menin's interactions with transcriptional regulators. In pink are menin's interactions in the DNA repair pathway, and in blue are menin's interactions in the cytoplasm, even though menin is a nuclear protein. Now, the interaction that has attracted the most attention is here circled in red, and menin's association in the MLL complex is responsible for histone methylation, a specific histone methylation which activates gene transcription. And in 2004, the discovery of menin in the MLL complex put epigenetics in the map of menin interactions. So far, a well-studied interaction of menin is in transcriptional regulation through interaction in the MLL complex in chromatin. This complex is responsible for a specific histone modification, the histone H3 lysine 4 trimethyl mark, which is a mark of gene activation. In this complex, menin is required for the action of oncogenic MLL fusions that cause leukemia. And it is possible that losing menin in this interaction in this complex on specific genes may lead to endocrine tumorigenesis. However, the question is, what is the role of menin-dependent specific histone modification in endocrine cells? This is the 3D structure of human menin with the minimal region of interaction of JUND on the left and MLL1 on the right. Now, the interaction with JUND is tumor suppressive, but the interaction with MLL is pro-oncogenic in MLL fusion leukemia. And again, this interaction has attracted a lot of attention for the development of inhibitors of this interaction to cure leukemia in mouse models and also now in some human clinical trials. For example, this inhibitor MI2-2 displaces the two menin binding motifs that are present in MLL away from menin, and this breaking of the interaction then drives the expression of this HOX gene, which is important for driving leukemia. So if the HOX gene expression is up, then it drives leukemia. When it goes down, then you sort of inhibit the leukemia and allow differentiation. And these compounds are being developed more and more to become orally bioavailable, not only for MLL fusion leukemia, but also in some solid tumors. They have worked very well in mouse xenograft models of castration-resistant prostate cancer, Ewing sarcoma, and glioma, and we await the results from human clinical trials. So in addition to this H3K4 trimethyl mark, this epigenetic modification, there are a few others that are listed here that are affected by menin loss. Both active and repressive modifications are affected. And the active modifications that drive gene expression are shown in green, and the repressive epigenetic modifications that repress gene transcription are shown here in red. And there is a lot of excitement for epigenetic drug therapy in model systems. What we need now is to look in tumors and find out whether and which of these modifications can occur together to specifically target those in an attempt at epigenetic therapy. I will now describe some highlights of the work on the mouse models of MEN1 loss and the functional studies of menin. The conventional germline homozygous knockout of MEN1 is embryonic lethal. The germline heterozygous mice can survive, and these conventional germline heterozygous mice depend on spontaneous second hit to the MEN1 gene for tumor formation. So this mimics the human MEN1 patient. Now, although the conditional knockout are not dependent on that spontaneous second hit, tumor formation still takes a long time. Also, in the germline knockout of the MEN1 gene in the heterozygous state, or the homozygous tissue-specific knockout in the whole pancreas, the alpha cells or the beta cells, all these mice only develop beta cell tumors, the insulinoma. And why is that? We don't know. And in the liver knockout, there are no tumors. So what is the reason for this tissue selectivity? And what is the reason for the delay in tumor formation, even in the conditional knockout? These are all questions for further investigation. Insulin-secreting pancreatic neuroendocrine tumors are the most prominent tumors in the mouse model of MEN1. This is a section of the pancreas from the MEN1 mouse model at age more than 15 months. This shows both normal islets, islet hyperplasia, and islet dysplasia. These are islets with increased number of cells. And all these islets, which are with the normal islet, the dysplasia, and hyperplasia, they retain the wild-type copy of the MEN1 gene until tumor formation, which takes about 18 months. So this mouse model offers an opportunity to study the molecular events associated with the process of tumor development. And studies in the mouse model of menin loss have been useful to analyze functional interaction for druggable targets. Here are three different MEN1 knockout models, that are using the conditional loss of menin in beta cells. These are double knockouts, so it's MEN1 knockout together with the knockout of either MLL1, RBP2, or beta-catenin. In the double knockout of MEN1 and MLL, the phenotype was accelerated tumorigenesis and shorter lifespan. In the double knockout of MEN1 and RBP2, the phenotype was decreased tumorigenesis and prolonged survival. And in the double knockout of MEN1 with beta-catenin, the phenotype was decreased tumorigenesis and prolonged survival. And such double knockout models and their results have implications for therapy. For example, here, the MLL-menin interaction is responsible for the histone 3 lysine 4 trimethyl mark. When you have normal levels of this trimethyl mark, there is no tumor. Menin loss leads to loss of this trimethyl mark. It's not just the loss, it's actually removed by a protein called RBP2, which is a H3K4 demethylase. So when the H3K4 mark is removed, there is tumor formation. So one can imagine if you have menin loss in the tumor and at the same time you get rid of this RBP2, you could restore H3K4 trimethyl mark and lead to reduced tumor burden. Similarly, menin loss can lead to beta-catenin activation, and that leads to tumor formation. And that's something that was shown in the beta-catenin MEN1 double knockout mouse model. So one can imagine menin loss and inhibition of this beta-catenin would lead to reduced tumor burden. So I think that there is a potential for continuing these studies and trying to figure out if the epigenetics field and the beta-catenin inhibitor field are coming up with more direct and specific inhibitors that can help us to understand how tumorigenesis can be inhibited or can be reduced in the MEN1 knockout tumors. In the next few slides, I would like to describe the data from my group in the past 10 years and how we are investigating the pathophysiology of pancreatic neuroendocrine tumors. As we all know, PNETs are either non-functioning or functioning. The non-functioning tumors do not hypersecrete hormones, so they are difficult to diagnose and they can also metastasize. And the most common type of functioning PNETs are the insulinomas, the islet beta cell tumors that secrete insulin. And I've already told you that PNETs are seen in the MEN1 syndrome, or they're mostly seen as sporadic tumors. And interestingly, 40% of non-functioning PNETs also show somatic MEN1 gene mutations. Therefore, we investigated molecular pathways that were affected due to menin loss by two different approaches. First, we looked at islet differentiation factors that could be modulated by menin knockdown or overexpression in the cell line Min6, which is a mouse insulinoma beta cell line. In this study, we identified HLXP9 as a target of menin. In the second approach, we investigated menin-dependent H3K4 trimethyl mark in wild type or menin null mouse embryonic stem cells. And in this study, we identified a long non-coding RNA MEG3 as a target of menin. This H3K4 trimethyl mark can be deposited by three different protein complexes. And we should note that menin is present only in this MLL1, MLL2 complex, which is responsible for this H3K4 trimethyl mark. So when we are looking at a menin null cell, it is possible that there would be plenty of H3K4 trimethyl mark that is deposited by these two other protein complexes. So what we would be looking at in a menin null cell is the trimethyl mark specifically deposited by MLL1 or MLL2. So both these approaches that we took on further analysis showed that loss of menin correlated with elevated level of the c-Met protein. c-Met is an oncogenic tyrosine kinase cell surface receptor. In the first approach, knockdown of menin in Min6 cells led to increased level of phosphorylated HLXP9 protein. Now, this is a beta cell differentiation factor. With anti-phospho-HLXP9 ChIP-seq and gene expression analysis by RT-PCR, we found that in cells that were not expressing menin, there was increased phosphorylation of HLXP9, which led to decreased level of this protein CBLB. So what is CBLB? CBLB is a ubiquitin ligase that targets oncogenic c-Met receptor for degradation. So less CBLB would result in more c-Met protein. With the second approach, we use anti-H3K4 trimethyl ChIP-seq and cDNA microarray to identify genes where there was loss of H3K4 trimethyl mark and loss of gene expression in MEN1 null cells. And what we found was that in cells where there was less menin protein, the expression of this long non-coding RNA was significantly reduced. We performed further experiments in a stable cell line that was overexpressing MEG3 versus cells that were transfected with vector alone. We studied these cells by cDNA microarray and by ChIP-seq to identify MEG3 binding sites. What we found overall was that when you overexpress MEG3, there is less c-Met expression. So the flip side would be when there is less MEG3, there is more c-Met RNA. So both approaches told us that loss of menin was leading to or coinciding with increased c-Met cell surface protein expression. So combined with our data, there is ample evidence for c-Met as an actionable target for therapy in pancreatic neuroendocrine tumors, and I will go over the evidence one by one. Our data showed two mechanisms for increased c-Met in MEN1-associated PNETs and high c-Met in human insulinomas. A group from Rutgers and Memorial Sloan Kettering studied 33 sporadic non-functioning PNETs by RNA-seq analysis. They found that aggressive PNETs show low MEG3 and high c-Met expression. Krampitz et al., a group from Stanford, found that high c-Met correlated with decreased overall survival in patients with PNETs. They analyzed 75 sporadic non-functioning PNETs for c-Met expression by a tissue microarray IHC. For tumors with low c-Met, the median survival was 9.7 years. And for tumors with high c-Met, the median survival was less, which was 5.3 years. They also reported that treatment with a c-Met agonist increased engraftment efficiency of xenografts of human tumors, indicating that c-Met signaling was essential for tumor growth. They made a xenograft of a PNET cell line and showed that anti-c-Met therapy could inhibit the growth of these xenografts and slow down metastases. Sunita et al., a group from UCSF, used the RIP-TAG2 mouse model. Now, these are mice with the rat insulin promoter driving T antigen expression in beta cells. These mice develop aggressive PNETs, which are mainly insulinomas. Anti-c-Met therapy in these mice reduced tumor burden and prolonged survival. The effect was moderate because these are very aggressive tumors. Now, following this work, Jennifer Chan of Dana-Farber has been conducting clinical trials with cabozantinib in advanced PNETs and carcinoids, and cabozantinib can attack both c-Met, VEGF, and I think and RET. So further studies on c-Met and PNETs will be helpful to know whether these findings can be translated into potential therapeutic options. So I have two slides on the summary and future directions, and that would take me 5 minutes, so we'll have 10 minutes for questions. The germline mutation in genes for familial syndromes, such as MEN1 and related disorders, have helped to direct genetic testing, confirm clinical diagnosis, early monitoring of tumors, and helps to exclude non-carriers. Genes identified so far do not account for all cases with syndromic features. We need to identify more genes for familial disease and for sporadic disease. Before that, we will have to define the familial and clinical characteristics of our MEN1 mutation negative cases. Regarding the tissue specificity of MEN1 associated tumors and no genotype-phenotype correlations, one can imagine if there are genetic modifiers that could account for specific tumors, for example, thymic and adrenal. And recent work from Dr. Statakis' group showed that patients with MEN1 patients with adrenal tumors may carry germline missense mutations in this gene called RMC5. And to tackle this question of tissue specificity, one could imagine if there are tissue-specific factors that are regulated by menin. Regarding sporadic tumors with MEN1 mutation, yes, up to 40% of parathyroid, non-functioning PNETs, and lung nets show mutations in the MEN1 gene. Again, more genes for sporadic disease remain to be identified. And one question here is contribution of epigenetic factors, which show mutations, although not recurrently in a specific gene encoding for an epigenetic factor, but collectively many of these neuroendocrine tumors are showing mutations in genes encoding epigenetic factors. So the contribution of epigenetic factors should be studied. MEN1 functional studies to find target genes and the epigenetic landscape in tumors have been challenging due to the small size of the normal endocrine glands that are even smaller in mice, and also due to the lack of mouse and human cell line, organoid models, and PDX models. And despite these challenges, some of the groups like ours have been able to identify c-Met as a druggable target at MEN1 and sporadic PNETs. Mouse models have shown a direct role of MEN1 in disease, and these can serve as great preclinical models for therapy. Such studies may help to direct research on tumor initiation and progression, and to identify and test druggable targets for therapeutic options, and they could also help us to identify biomarkers of disease or therapy. Last but not the least, the MLL-Menin interaction inhibitors that have been useful in MLL fusion leukemia in mouse models of some solid tumors and in leukemia models. And we wait patiently for the human trials to see how this MLL-Menin inhibition can help patients with leukemia. I'd like to acknowledge the valuable contributions of my collaborators and colleagues at NIH, and the data that I presented today not only show work that was conducted at NIH, but also work from all over the world. And many investigators in the labs have made valuable contributions. And here are individuals that have had the good fortune of working with on various genes. Some have moved on to other responsibilities. Not listed are names of individuals outside of the NIH or outside USA. I want to specifically acknowledge my branch chief, Dr. Lee Weinstein, for his support and financial assistance. Vishali Parekh, who takes care of all of my mouse models, clinical fellows and postdoctoral fellows, whose contributions are tremendous when one works with so many different techniques and analyses. And I want to specifically thank Dr. Haidira Del Rivero for her outstanding collaboration over the years. And with that, we will continue to do so in the future. And I thank you all for your attention.
Thank you very much, Sunita, for a spectacular overview of the Menin protein, which, as you know, I also have a vested interest in. So it's always great to hear people talking about it, to put it out there for everyone to hear. If anyone has any questions, feel free to either put them in the chat or just raise your hand and we can go round. So
I don't see any in the chat, yeah.
Yeah, I'll keep an eye on the chat. Whilst people are thinking, I mean, I've got many questions that I'm sure, as you know, we could discuss all day long. But one of the things I was going to ask was, so I think a lot of us are at the moment searching for a new gene that causes these MEN1 syndromes. But I wanted to hear your opinions on whether we think there is another gene or whether it's going to be a polygenic situation. So actually, there's going to be either common variants occurring in a number of different genes at the same time that actually is contributing to this instead.
Yes, Kate, thanks for bringing up this discussion. And everything that you said is correct. So there could be one gene, no gene, multi-gene, or not even a genetic component, but something like a phosphorylation event or a gene expression event that is common to the tumors that we are studying. So anything is possible. And I think collaborative efforts are really required to follow this path and to find out if all these 10 to 30% of MEN1 mutation negative cases are real, and do they really carry a genetic component or not? So yeah, I'm sure everybody has their favorite set of DNA samples, and I think we should all come together and try to figure out what to do about this. Thank you, Kate.
Yes, that's anyone else? Go on, go for it.
Oh, sorry, I just want to ask a question. And again, this is more from the clinical perspective about the MEN1 and what you talk about Menin, because that's one of the projects I've been working with you, and I have an interest to find a target for this. And we know, for example, the cabozantinib is one of those drugs that has activity on what you just described, CMET, and we, based on some of the data, I mean, I think that there is an importance of this protein and in order to as a target for treatments. My question to you, and again, maybe more from the therapeutic levels, is like, how do you see that in the context of MEN1? Because in my experience, and that's something that we're trying to change, is that MEN1 sometimes don't qualify for clinical studies because they have different other tumors. And that's kind of like an exclusion criteria, that because they have this tumor or that tumor, they may not be eligible for that. And I hope that we can change that. But I don't know, Sunita, I mean, Dr. Agarwal, I just wanted to know your thoughts about it, because we have, for example, the cabinet study, which is Jennifer Chan's study, and I don't know if they're including any MEN1, but since that has been your lifelong, Dr. Agarwal, I mean, I just wanted to know what your thoughts about it.
Okay, look, I'm a basic science researcher, so I will not talk about therapy. Right. What I can say is, yes, multiple endocrine tumors and multiple tumors in MEN1 patients. And what is required is to study these tumors and find out if all or some have the CMET component increased on the cell surface, in the cytoplasm, and some are also finding it in the nucleus and other diseases. So clearly a good survey of the tumors will be required before we can take it into this general MEN1 category. Right. But having said that, the way MEN1 patients' tumors therapy has been progressing, we're all extrapolating from what's going on in the sporadic tumors therapy. So if we can help patients with sporadic PNETs who would get a single tumor in the pancreas as opposed to multiple tumors in the MEN1 patient, again, that will be something that I would never try to do. I'm not a clinical person. But what I would like to do is to study these tumors and see if indeed CMET is so significantly upregulated that some of the inhibitors can help. And one point we can make, Dr. Del Rivero over here, is that there are no mutations in the CMET gene in any of these neuroendocrine tumors, as opposed to other tumors where CMET therapy is successful.
Wow, that's good to know. So maybe this could be used as a biomarker, who knows, but thank you.
Yeah, okay. For biomarker of an aggressive tumor, yeah, that's a good point. Very good point.
Yeah, great. So I think John has a question here for you. I mean, I don't know if you want to say it out loud, or I can read it from the chat. It's entirely.
I'm happy to. I just wanted to kind of get it in while I was thinking about it.
No, that's fine. Go ahead.
Okay, thank you. I have two questions. I think both are really interesting. I don't know. I'm interested. So my question, first question, I guess, is, would we want to look for a unique MEN1 mechanism for all MEN1 related syndromes? Syndrome tumors. Or do you expect that each site is going to be contextually dependent? Like, let's pretend like someone wanted to develop a computational model of the interactions and see what to see if that computational model could recapitulate some of the disease states. Do you think that would be that you need really would there be one model that suffices for everything, or do you think that it really matters what tissue you're in?
So this is it's a very difficult field to be in, this whole protein-protein interaction business, because most of the studies are done in non-MEN1 tissue-related cell lines. And lines have other mechanisms of why they are cell lines and proliferating. They're not really mimicking the MEN1 tumor. So you really need something that will mimic MEN1 tumors and then try to study protein interactions and what have you, the target genes. How do they relate to the MEN1 tumor situation? And the big chart that I always show of the MEN1 interacting proteins, some of them are just single publication papers, so with no follow-up. And what do I do with those data? Do I start following up on every gene? Well, then you come up with your favorite gene and you go after it. So to answer your question, I think a collective effort would be required, a computational effort like you're describing, where you come up with 4 candidates and then you try to study them in all the tumors. Now, given that menin loss is the unifying factor for all these tumors, one would assume that there could be a single event that is responsible downstream of menin loss for all these tumors. It's possible.
Yeah. Great point. Great answer. I got to ask, if I'll be permitted, I'm also curious, have you seen any evidence in these studies that you've got extensive knowledge of that suggests that MEN1 patients might be able to take a preventative medication or something that might, what is the future, what possible futures would there be? I understand you're not a clinician and I'm not asking you to speak to that. However, since our clinical treatments often evolve from animal and cell line models, I was wondering if there was anything that you would observe.
I mean, you know, the mouse model of MEN1, this one where you specifically knock out MEN1 in the beta cells, start developing tumors after 8 to 10 months of age. One can imagine if there is a compound like this for preventing tumors, you could start feeding the animals as soon as they are born, as soon as they are weaned and off of the mother's milk, and start putting this compound in the water and see what happens. So we do have a model that could help us to study. And I think Kate Lyons would be set up to do that type of study because she's publishing data about hundreds of mice. So your paper with the KRAS discovery is really good, Kate.
Well, thank you. Well, actually, following on, because we did a similar thing, not
Like,
necessarily
I hand the ball
intentionally.
to her now.
I'll carry on. No, because we actually did it with Paceriotide. And it did show that if you gave Paceriotide, it did have sort of a prophylactic job. So we did that on the conventional mice. So of course, because not every single mouse develops the tumors and they develop them at different time frames. And we MRI scanned them at 2 time points. It wasn't completely sort of the same type of study to see if it could prevent the tumors occurring, but it kind of gave us an indication and it looked like it could. I think the big thing, and Heidi will be better to sort of help on this front, is that of course things like Paceriotide come with a lot of side effects, and it's all about when you want to give it, because you don't want to waste a therapeutic option by causing resistance before the tumors have occurred, and also you don't want to make someone, you know, the equivalent of diabetic by giving them a drug to prevent a tumor that then causes greater health problems. So I think we need to know a lot about the science side. And I think, as Sunita has very, very nicely shown, it's extremely complicated. There's so many interaction partners that what you target and how and when and whether each person will be the same is the biggest problem that we have. And until more people, other than me and Sunita in the world, are looking at MEN1 and Menin, I think, you know, we've got a long way to go. But in theory, yes, you could do it. And we do, as Sunita says very rightly, have the models to start looking at that.
Yeah, and what you mentioned, John, about the preventing tumor formation, I think that would be ideal. That would be ideal.
I assume everyone agrees with that. Thanks for all your work in this area.
Thank you.
That's wonderful. And thanks for the updates as well.
Anytime, and reach out to me for anything. I'm always available to answer questions or to discuss and, you know, brainstorm ideas if you have any.
Thank you.
Right. I'm guessing in the interest of time, I might just pop back to Selena, see if she's got anything she wants to say before. I'm guessing we should probably round up pretty soon.
Yeah, no, I've got nothing to say. That was really, really interesting. I am very, as Kate knows, medically, I have no knowledge whatsoever. So anything like that really does quite often go over my head, but I still find it interesting. So I think that is really important, that even when we don't really know what we're looking at, that you're giving amazing talks that are actually, some parts of it I do understand, and I think that's it's progress for me because I am actually starting to, you know, learning things from all these talks, and I'm so grateful for you to give up your time just to give these talks to us and allow us to record them and make them available.
Thank you.
And I really do encourage, as you say about the collaboration, that really is what Simon set up this foundation for, was to encourage collaboration between as many people as possible. So thank you very much.
Thank you, and everybody have a nice day. Bye.
Thank
you
you
so much.
Oh, thank you so much. Bye.
Bye, everyone.
Thanks.
Thank you. Goodbye.
Thank you. Bye.